have a watch her walk afterwards? Like, did her foot progression angle and stuff
Yeah.
improve? I know she got back to volleyball and did well, but I was just curious.
Yeah, I didn't, I don't know if I had her walk or not. I can't remember specifically in that
Yeah.
case, but yeah, that would have been an
Interesting
interesting
to see
video
how
to
it
put in that
changed.
talk. Yeah.
Yeah. So I'm Brett Crist. I'm at the University of Missouri, and we're going to talk about when to address the femur. It sounds like a pretty simple topic, as we've already talked about this morning. The disclosures are available here. And so sometimes it's pretty easy when you have severe dysplasia. Obviously, this patient has severe dysplasia on both sides. It's having bilateral hip pain. She wasn't that active, but she even couldn't really go to school and walk very far. This is a different patient. I'm just going to try to show options since there's not a ton of literature about it. This is a 15-year-old bilateral hip pain with a history of skiffy on the right side that was prophylactically pinned on the left. And now both of them are bothering him at about 5 years later. This is an 18-year-old with bilateral hip pain. We'll go through these each as we go through it. And then this is a 30-year-old who was referred after PAO. She has a history of Ehlers-Danlos and has a pubic osteotomy non-union and issue of femoral impingement that we'll go through. And so the objectives are to list the indications for when to address the femur, summarize the current literature, which is pretty minimal as far as when to do it, as we just were talking about, and then talk about the different surgical techniques. And Joel Williams is going to talk about some cases this afternoon too. So this is basically an algorithm that the burn group came up with for when to address do periacetabular osteotomy, when to add the proximal femoral osteotomy, and kind of the order. And it's a very detailed algorithm, as you can see, and this is continued parts of the algorithm, including if they have residual problems after PAO. And really emphasize, like has been mentioned a couple times, the functional views. This is kind of the summary of the cases that they had, where they did intertrochanteric osteotomies, relative femoral neck lengthening, femoral neck osteotomy, and then femoral head reduction osteotomy, as some of the cases were presented this morning already, similar to these. And so they included both extra and intra-articular osteotomies, which these are obviously very complex cases. And then this is published out of St. Louis that looked at, when does the femur potentially cause the symptoms? And in looking at 314 patients, the average femoral version was around 20 degrees, plus or minus 11 or 10, and didn't seem to affect symptomatology in that particular range. And so we'll kind of go through different ones. So this is that 14-year-old bilateral hip pain patient, both sides involved. And I'm just trying to go through the radiographic stuff just to try to get through the cases quickly to stay on time. But this is her AP view. She has a negative lateral center edge angle. Her anterior center edge angle is 3.6. Tonus angle is 31.9. And this is her lateral view. You can see she has a large cam there. So she has severe dysplasia involving both sides. And this case was done actually about 15 years ago. Jeff Mast came and did both sides with me through a visiting professorship through the AO, and this is his great drawings. And so the plan was for addressing the acetabulum with a PAO, but also address the femur with varus and retroverting. And so we provisionally did the femoral osteotomy and pinned it, and then did the PAO and pinned it just to try to make sure to try to increase congruency and minimize maybe over coverage anteriorly. And this is what she looked like post-op. And then this is after the other side was done. And that was at 2 years. And then the second case was valgus and anaverting. So this is that 15-year-old with skiffy, and he had some cranial acetabular retroversion. He underwent arthroscopic labral repair by one of my partners and camera section. And then this is his anterior center edge angle, 41.8. This is his labral tear, so we didn't feel like we wanted to leave that alone, so that's why that was addressed arthroscopically. And then this is, I like to use the whole pelvis just to make sure I'm getting the axis right for what I'm using for retroversion. So he had about 10 degrees and 3 degrees of femoral anatorsion. And so these are the problem list. And so he underwent his arthroscopic procedure. Then I did the femoral side at that time. And then 2 weeks later did the PAO. And these are the postoperative images. And then you can just affect one plane, so both the coronal plane or rotational, as we talked about. So this is the 30-year-old female who had the PAO previously. She continued to have symptoms. The thought was that part of it may be her pubic osteotomy because she had anterior groin pain, but then she also had like mechanical symptoms when she went into hip extension during even just gait, where she had to wear a brace to try to prevent that from happening. You can see on her AP pelvis, she has basically a groove in her ischium where she was impinging that correlated with some edema on her MRI, but her overall mechanical alignment wasn't abnormal for the most part, maybe just a little bit medial on both sides. So she underwent varus and osteotomy to increase offset, and I tried to minimize the leg length difference by using the wedge to try to restore some of that leg length and then fix that with that screw, and increased her offset. So that's immediate post-op, and then that's a year later. And obviously, varus osteotomies are going to see more mechanical stress and a higher risk of failure, so they're going to take longer time healing. She actually wants to get the other side done now, so she's a glutton for punishment, I guess. But rotational femoral osteotomies that we've been talking about a little bit. So I'm a lot more aggressive with the femur. And these are just, we talked a little bit about how to measure it. This is a study looking at 4 different techniques and compared it. I like to use the Jarrett technique because for me it's more repeatable, and it also had lower inter and intra-observer reliability. And that's kind of what's been shown, at least in the talks this morning. So one thing I like to do is lateral free-legged. Usually the person who's up there is making a face, so that's why I blocked the fellow out. But lateral positioning, you do have to be careful if you're using a nail that the proximal segment isn't going to get externally rotated with the handle. So it does, just require continued attention to detail. And then you can, I think it's easier to use the Mayo stand to help maintain the position of the distal segment. There's different techniques for intraoperative evaluation that I think are helpful, most of which has been published on femur fractures and how we can get the rotation wrong. But the lesser trochanter profile is pretty subjective to me. It's not as easy. Lateral imaging of the knee for me is more reproducible. So Paul Tornetta published the true lateral technique, so you get an axial lateral of the hip and the knee, and what the difference is what the rotational difference is. So that's 0 degrees, and this study out of Utah looked at using different techniques, including the neck horizontal angle, and then submitted it to 85 different level surgeons, 8 surveys with 20 different, falsely positioned their cadaver bones with 10 specimens. Lesser trochanter profile, and the head axis was better than the true lateral technique, but it took up to about 20 degrees of malrotation for over 60% to be identified. So the conclusion was, use multiple techniques. Obviously, if you do more than one technique, you're going to be more likely to be better at determining differences. And then we saw a little bit about what's normal. This is out of Marty's AO osteotomy book, but around 15 degrees for the femur. And we can discuss about what's considered abnormal, plus or minus. And then, like we talked a little bit about this morning, don't just look at the femur in isolation. You want to look at the acetabulum as well as the tibia. And then these were CT scans done for other things. This was published out of the shock group. They had 5 reviewers that had both sides, and just kind of looking at side-to-side differences and the mean variation between the raters as well, and repeating measurements. And so the pooled mean variation was about 1.6 degrees, mean side-to-side difference was 2, and only 5% had more than greater than 15-degree difference. So usually one side is going to be pretty similar for patients. And obviously this isn't somebody with hip dysplasia. These are just patients that had CT scans for other reasons. This I thought was pretty interesting since we have 3D C-arm capability now. They created different models in the shaft osteotomy and had two fellowship trained surgeons review using the true lateral technique, and you can see the images for different degrees of version or torsion. And this is what they did. They compared regular fluoro to the 3D C-arm, and the main thing is that the 3D was much more accurate, which makes sense because you're recreating the CT scan. So this is a girl, we talked a little bit about, the femur may not play a big role in their symptoms, but this girl had bilateral hip pain. The left side was worse. She had two MRIs 6 months apart. The second was an MR arthrogram. Showed no intra-articular pathology. Her acetabular indices looked normal. She wasn't borderline. But really the only abnormality on imaging was this 46 degrees of femoral antitorsion. And so the problem list was basically that. And so I've actually gone to where if they have less than 5 degrees of femoral antitorsion, it's at least a discussion to have if it's with or without a PAO, and they have intra-articular pathology or hip pain that's not getting better with conservative treatment, or if they have more than 25 degrees, because those are the patients that have had come back having not addressed the femur, that they're still having symptoms. And so this was the intraoperative true lateral technique. So it correlated pretty well with her CT scan. So the difference was 45 degrees rollover. And then I put the reference wires in, ream, and then do, if they're big enough, there's a medullary saw that you can use. For these smaller patients, she required a smaller nail, a 7mm nail. But did a small open vastus elevating osteotomy, do the correction, re-ream, and then place the nail in the new position, and then do a lot of kind of going back and forth to make sure the true lateral technique matches what I hope the correction is, and then place the locking bolts, and that's kind of the final, so around 15 degrees. And that's what she looks like. This was I wanted to present this case. She's only about 8 weeks out now, but it was really the only time that it was only femur with no intra-articular pathology, just to show that it could be a cause. So the take-homes, I think for the femur, the data is lacking, and so don't forget about it. And there's obviously multiple options that you can do, including multiplanar and then pure single plane or rotational osteotomies as well. Thanks.